Welcome to ICU Primary Prepcast. Hi, this is Swapnil. And today we are going to discuss another primary snippet about serum creatinine and creatinine clearance. So what is creatinine? So creatinine is a small molecule produced endogenously from the breakdown of creatine and phosphocreatine. It is a non-protein nitrogenous waste, just like urea. Now, where does the creatine come from? Creatine is produced in liver, pancreas, and kidneys, which is a byproduct of transamination of arginine, glycine, and methionine amino acids. So majority of the creatinine comes from skeletal muscle. So basically creatine and creatinine. So creatinine is a byproduct of breakdown of creatine and phosphocreatine, and creatine is produced in liver, pancreas, kidneys from transamination. Now, because majority of the creatinine is produced in skeletal muscles, usually it is influenced by muscle mass. Creatinine is freely filtered by glomerulus due to its small molecular size. And usually it can be measured in serum, plasma, or urine. So how do we measure creatinine? We usually measure creatinine in serum. And the two methods that we can use, one is the chemical method, or the second is enzymatic assays. Now, chemical method is also called as Zaffe method, where we use picric acid. So creatinine reacts with picric acid in alkaline environment to produce orange-red colored product. And this method has its own drawbacks. First of all, it is not specific to creatinine, and it can be also affected by other substances present in serum, such as ascorbic acid, bilirubin, acetone, and cephalosporin. So obviously it is not accurate when you got jaundice or when you got a ketoacidosis. And that's why sometimes when you see the results of creatinine cannot be displayed when you got a very hyper bilirubinemic state. Now, enzymatic assays use the enzyme called as creatinase, and it uses the spectrophotometer to measure the conversion of NADH to NAD+, or conversion of hydrogen peroxide to water. Now, all these methods need calibration, and that's why sometimes the creatinine measurement can vary between two labs, even the sample is taken from the same patient. So the calibration is really important. So what are the advantages of using serum creatinine? It's very easy to measure and it's cheap. Now, what are some of the limitations of using serum creatinine? As I mentioned, because the majority of the creatinine is produced in skeletal muscles, usually it is affected by muscle mass. And that includes at the extremes of ages, where you got low muscle mass, such as elderly or infants. Similarly, the catabolic states where you have low muscle mass, such as anorexia, or on the other spectrum, when you have higher muscle mass, like athletes, will have a higher creatinine values. The serum creatinine is also secreted by renal tubules. So it's freely filtered by glomerulus, but it's also secreted by renal tubules. And that's why when we use serum creatinine to measure GFR, it ends up in overestimating GFR. And when you plot a graph of serum creatinine to GFR, it is not a linear relationship. And in fact, it is a hyperbolic relationship. So if you want to access this show notes, you can go to www.critcareedu.com.au and access all these show notes, including the graph that I'm talking about. So when the GFR drops below 25%, rise in serum creatinine is quite disproportionate. So it's not a very accurate measurement of GFR. Also, because it is secreted by tubular secretion, the drugs which compete for tubular secretion, such as trimethoprim or cimetidine, influence serum creatinine values. And that will lead to increased serum creatinine even if when the GFR is constant, because these drugs are competing for the same excreting mechanism. In terms of the diet, the protein-rich meals will lead to increase in creatinine values. Similarly, hepatic diseases will lead to impaired conversion of creatine to creatinine, and that will lead to decreased values of serum creatinine. Now, on the contrary, in the rhabdomyolysis, there's an increased production of creatinine, and that's what we see where we have increased serum creatinine in patients with rhabdomyolysis. With regards to age, serum creatinine levels drop rapidly within first month of birth to 0.25 milligram per dl, while the normal levels are 0.63 to 1.16 milligram per dl. Then subsequently it rises to the adult value, and the serum creatinine value remains constant between the age of 20 to 70 years. After the 70 years, again, serum creatinine levels start to rise again with the age. Now, what is creatinine clearance? It is the volume of plasma cleared of creatinine per unit time. And it needs 24-hour urine collection to measure creatinine clearance. You can use some of the formulae to estimate creatinine clearance or also GFR based on creatinine clearance. One of the very popular formula that we use is Cockcroft-Gault equation, which calculates creatinine clearance as 140 minus age multiplied by weight in kilograms divided by 72 multiplied by serum creatinine in milligram per 100 mils. Now, as you can see, the limitations of using creatinine clearance to calculate GFR includes all the limitations associated with creatinine measurement to start with, because it heavily relies on serum creatinine values. The second is it is an estimate and it's not actual GFR. As per the equation, it depends on age, body weight. It's also affected by sex and ethnicity. And especially in the critically ill patients, where we have a problem of augmented renal clearance, where the GFR values may look normal, but obviously patient has got augmented renal clearance of certain drugs, and the therapeutic levels of those drugs can be challenging. For example, antibiotics like beta-lactams. Issue with the large fluid resuscitation, which usually dilute serum creatinine, and that gives us a pseudo sense of improving renal functions. And also patients who are on CRRT or ECMO usually mask raised creatinine. So the bottom line is creatinine and creatinine clearance both have got limitations in terms of their measurements as predictor of renal function in critically ill patients. And we need to understand those circumstances in which these measurements are not going to be accurate. We'll be back in week's time with another primary snippet. Till then, goodbye and have a nice time.